Oh, hey, everybody. Welcome. This is Joe Moore, Psychedelics Today, joined by Court Wing. We're going to do a live talking about why it's vital to understand chronic pain and the intersection with psychedelics. And Court, you can maybe talk to us a little bit about your time at Pain Week and also the recent paper that you contributed to that was recently published. And so I guess like just to set the stage, because not everybody knows you, even though you've been on a ton, but you've got a really interesting background, and we've been collaborating for over 3 years now, over 4 years now. I don't even know.
Four, because I got a hold of you within like less than 2 months of leaving the Psilocybin trial at NYU in 2020. So yeah, it's been 4.
Wow, awesome.
Yeah.
So I've loved collaborating with you, learning alongside you, and yeah, it's been quite the project. How do you like to describe what you're up to in the psychedelic space?
Sure. First and foremost, my company REMAP Therapeutics was one of the very, if not the first company in the space specifically highlighting the role of psychedelics in pain resolution and treatment, as well as highlighting the fact that these compounds are impact boosters for neuroplasticity, and so therefore they make adjunctive therapies like something as simple as physiotherapy far more impactful and enduring. And then secondly, and really in conjunction with it, because you almost can't do one without the other, is our role with the Psychedelics and Pain Association. So, which is a collaborative effort between Psychedelics Today, Cluster Busters, and REMAP Therapeutics. And just highlighting, the fact that this research has been ongoing for decades, but we're really in this golden era right now of profound discovery, as well as patient advocacy. Cluster Busters has been working in fostering both research as well as access for people with some of the most severe pain conditions known to medicine out there. And so they've been, working closely with Yale as well as other institutions to get research completed. And also they have their own, organization where they have patient advocacy conferences. So there's one happening just this week in Chicago. So I think it's like their 19th annual Cluster Busters conference. They were one of the very first online, I think, to feature a grow guide specifically. So, access was never a point of, of contraction or denial for anybody with severe cluster headaches or migraine now, and so many other headache conditions. But we're seeing that broaden out into, the much larger chronic pain communities.
Yeah, right on. So thanks for sharing that. And I've loved being involved. And, folks like Bob Wold have been a hero for a long time. And it's just, amazing to be able to work on alongside him and his team. And yeah, all the folks that you've brought in as well. It's been amazing to kind of actually feel like we're making a difference on the science by getting people connected and talking and not to mention that baseline ed that you put together, which is really, really incredible that there's free ed available, kind of like give people a baseline understanding of what we're talking about here.
Thank you for bringing that up. Yes. So, one of the first things that REMAP did was, two different things really, almost not quite at the same time, but pretty close to it. Launched the first online course that we're aware of, integrating neuromuscular rehabilitation with psychedelics, trying to give you this very broad overview of what this would look like within a clinical setting, or at least a clinically informed setting, perhaps, based on all the latest neuroscience and all the research that was available 4 years ago. And then we hosted at the time, as far as we know, the world's first Psychedelics and Pain Symposium with the top researchers in the field. We're just about to host our third annual Psychedelics and Pain Symposium this September 28th and 29th. So it's now a 2-day affair as opposed to a 4-hour affair the first time. And day one is going to be free. And the second day, our professional day, is sliding scale. Once again, with all the latest research that's coming out, day one is aimed more for people that are looking to get an introduction to the history and practice of psychedelics and chronic pain, as well as other physical conditions like autoimmune, neurodegenerative, or infection-acquired illnesses, chronic illnesses. I'm sorry. One of the offerings that we already have out there, as you mentioned, is through the PPA, the Psychedelics and Pain Association. We have about 7 hours of free open coursework with many of those same top researchers and practitioners that are out there sharing, what is the neuroscience and the mechanisms of action that lie behind why psychedelics could be so effective for either the relief of, or in some cases, resolution of, chronic pain and other physical conditions. So, and that's available, I believe, if I'm correct, through Psychedelics Today's web hosting and their, vast media platform, which is just truly, it's like the Wikipedia of psychedelics, honestly, and it's such a breadth and depth of subject matter and availability. So, that was always why I was attracted to PT when I, was first coming out of the trial at NYU. I just thought you guys had the best coverage overall. So
Yeah,
maybe
thanks
it's
for
because that's just my height anyways. So
well, we came from a lineage, right? It's not like we kind of we're just lone agents, right? We're kind of like tucked in with this organization that goes back and before Groff, and I really excited to be able to like have that grounding to then say this is really important. I'm going to take this seriously, and yeah, the spidey senses were just up.
Yeah. You brought it up initially. So I should follow up. So we just got back from Pain Week in Las Vegas, just literally this past week. So Pain Week is one of the largest professional medical conferences on pain in the entirety of the United States. So clinicians, practitioners, different companies, both pharma as well as adjunctive therapeutic companies are there presenting on the latest research. And there's an exhibitor hall. But we were very fortunate to be invited in by them to do a presentation on a patient perspective and clinical evidence, real world and clinical evidence for psychedelics and pain. So board member of Clusterbusters, Joe McKay, who is a firefighter that worked at the Ground Zero site after 9/11, who developed cluster headaches. He came and talked about his experience going through standard of care medical treatment and how that did not work for him. And then eventually, just out of desperation, because the severity of his what became chronic cluster headaches, was driving him towards, as it does for many chronic pain patients, towards suicidality. And then he became aware of, I believe it's through a National Geographic special, became aware of psychedelics and cluster headaches, and then of Clusterbusters, the longest and oldest patient advocacy organization for cluster headaches, and got in contact with the founder, Bob Wold, who told him, this is what we do. These are the drug interactions you have to watch out for with your standard of care medications when you're involving psychedelics in there. And just brought him profound relief. And I discussed my experience of going through the NYU Psilocybin trial for major depressive disorder back in March of 2020, and how, yes, I did go into like profound and immediate remission from my depression, but it also brought me profound and immediate remission from my low to moderate ongoing chronic pain. But very, very fortunately, because I have a background as a pain and performance specialist, I was able to identify the mechanisms and pathways that were leading to the resolution of my physical pain in real time, and then just started prowling through the literature, based on what I already knew. So I was able to, quickly find things, and just how everything blossomed out of that. And also some very, very unique, fortunate timing, So, I don't want to discount that, but like the fact that, Dr. Joel Castellanos's paper and the entire team out of PHRI at UC San Diego came out 2 months later after my dosing, chronic pain and psychedelics, a review and proposed mechanism of action. I mean, there you go, and then, and that was just as I was exiting the trial, but I had already had the revelation, like this would absolutely work for phantom limb pain, because I had worked with, more than a decade earlier with a young vet returning from Iraq who had very severe CRPS, complex regional pain syndrome, and eventually, out of desperation to get out of pain, had his leg, a whole fully functioning leg by all appearances, had it surgically removed. But that's because, standard of care opioids and gabapentinoids and all those other compounds weren't effective, and his leg was on fire 24/7. So I had already been, that had been the back burner of my subconscious, as the way these things usually work for me, just kind of how do you resolve this? And then this paper comes out detailing how Albert Lin and V.S. Ramachandran, the inventor of mirror box therapy, had combined high dose psilocybin and mirror box therapy together, and within 5 weeks he was in profound remission. So hopefully that's not too circuitous there, but there's a backstory here. There's a backstory, folks.
So before we jump into the new paper, just wanted to briefly mention that Vital's kicking off next Tuesday. So the 17th classes start, the 16th is orientation. So this is the 4th round of Vital, and there's still time. So Vital, psychedelictraining.com if you want to learn more. And yeah, feel free to email and ask questions if you'd like, and feel free to just go in and apply.
Best certifications I've ever gone through was navigating psychedelics for clinicians and therapists in November of 2020. Just super, super fortunate to go through that. And just it's really like an ocean of information, that I can just repeatedly dive back in. It's like, oh, wait, what was that whole thing about? And then suddenly, there's this whole line of investigation to pursue. So just have always appreciated you guys had that out there as early and broadly as you have.
Yeah, thanks for that. And eventually we'll get you through the whole Vital program. So so I like to think of it as a large kind of liberal arts training around psychedelics, as opposed to like a really hyper specific, this is the protocol you're going to run through for everybody, because that's, medicine wants to like reduce to like one treatment for all. And I think stuff's a little more complex than that, perhaps for some frontline treatment options. But once we get a little advanced, like we have to, dig into the nuances, and it's deep. It's a really complex landscape we're playing in here with psychedelics.
It's always fascinating to see whether a practitioner is more principle based or protocol based, and there can be protocols for certain procedures, absolutely, of course, but eventually when you get in there with the individual client, you're gonna have a plan and it's gonna fall apart, and then you'll kind of refine your way as you like fit yourself to the circumstances that are pragmatically in front of you. And then that's when like some really startling things can emerge, I think.
Right. I'd agree. So, yeah, it's this idea of like studying theory and practice as opposed to just studying practice. And I think theory and practice need to be married in a really key way. And and I love it. And I love being able to provide this to people from all walks of life, from anesthesiologists to yoga teachers, from therapists to drug and alcohol counselors. It's really, really helpful across the spectrum, for sure.
The people I've talked to that have gone through it have just raved. So it's exciting when people's expectations are getting, superseded. So that's awesome.
So let's talk about the paper that you helped with a little bit there. What's the title of this new paper?
Okay, so probably I should pull that up so I don't get it wrong. It's give me one quick second. You would think I'd memorized it, right? I would have memorized it, but sadly, I'm pretty sure it starts with the word refractory. I believe it's refractory CRPS treated with, I have so many things in front of me. I believe it's refractory CRPS treated with psilocybin. Here we go. My apologies. Refractory CRPS pain treated with psilocybin, a case report. Right. So once again, CRPS is complex regional pain syndrome. So one of the most difficult pain conditions to treat and to have. It's not like it's a pain Olympics. Perhaps in terms of total pain intensity, only cluster headaches tends to be more severe. Not that each complex pain condition doesn't have its own very unique, extraordinarily challenging difficulties with it. But do you want a little background on it, or should I?
Sure. Let's however you want to present the paper.
Sure. So the case study is about someone that we've interviewed, and full disclosure, someone I worked with, Lynn Watkins. She was a 25-year veteran, U.S. Air Force, a JAG officer judge, but she also had 20 plus years of complex regional pain syndrome, type 2, which means it was actually one of the types where it was due to an original nerve injury. And complex regional pain syndrome is a pain condition where you can have a seemingly innocuous injury, or even no initial injury, but the central nervous system starts responding to all incoming sensory inputs as if they're extremely noxious injuries, and comes out with this hyper responsive, aggressive pain perception that doesn't just spread along the local nerve distribution that you would see in the dermis, right, in the skin, but it's actually for like a whole global section. So this is why they call it regional. So it's like the whole upper leg, the whole lower leg, the entire foot, or the entire hand. So it's like a glove rather than like just this part of where my median nerve is spreading sensory input. So anyways, it tends to predominantly affect women, tends to predominantly affect older women, not exclusively. Early on, coming out of the NYU trial, I actually got a referral to a patient from James Fadiman, and this was someone who had CRPS. And just as an example, so this is a person who had been a professional, IT professional, and then they had a injury, and then they had like a seemingly simple medical treatment for it, and perhaps a nerve got nicked or something like that. Who knows? It could be, and it may not be, because other people get nerves nicked all the time and no problem. But as a result, they developed CRPS. And because of that, they couldn't wear clothes on that part of their body anymore. Right. So like you develop what's known as allodynia and hyperalgesia. So the pain signals that are already there are just, 10x from what they normally are. And then normal sensation becomes extremely painful. So think of when you get a bad sunburn, how like putting on clothes is like, no, or someone, you get a breeze across your leg and it's like, anything like that is just normal input becomes extremely, extremely painful. It's much more severe in CRPS, unfortunately. So, So she had a injury from a military. She was getting an operation within the military. There was some malpractice, and as a result, she lost all sensation in one of her leg nerves, and then that started like this cycle of pain for her, where it spread from the size of maybe a 50-cent piece to slowly, the size of the page of a book, to eventually like the whole half of her leg, and then started traveling around her body. And that's not unusual, people with CRPS. And then it's known as this condition of central sensitization. The central nervous system is hypersensitized to all inputs. And so it seems to be like lighter fluid on any further developing issues. So at one point, she developed what's called glossidynia, burning mouth syndrome, like years later, where like she got exposed to maybe a really bad batch of sriracha. And when she was having some spicy sauce on like sushi or something like that, and her friend also had the same experience, except a day or so later her friend's mouth got better, and Lynn's just turned into this nightmare of like feeling like her mouth was being scalded or her teeth were getting pulled out, right? And then as a result of that, she also developed uh, depression and anxiety and PTSD, exacerbated from both situations, in her childhood, as well as while she was in this very, very demanding position as a JAG officer judge. So working within military justice, it's extremely complex. There's, very difficult circumstances in the same way you would see in civilian courts of law, but under the very specific circumstances of the military justice. And so, very, very high level demanding job. And eventually she had to medically retire. And she had multiple interventions that unfortunately didn't go well. And those got worse. Anyway, so long story short, eventually she was doing nearly monthly ketamine infusions. Ketamine is one of the only prescribable medications for CRPS. She was finding some relief, but it was starting to diminish and the duration was shortening. And she reached out to someone she knew that was in charge of an organization that we both know, Ketamine Task Force, and Kimberly Jarowiecki referred it to REMAP Therapeutics. And we did 3 months of pre-mapping with her, doing, qualitative, quantitative sensory assessments, and determining, which neuromodulatory interventions she was most responsive to, prepped her for those, doing regressions and progressions of those. And then, and also taught her best practices in risk reduction and benefit maximization, and getting her ready for a non-ordinary state of consciousness. And then went on a retreat in Colorado, so it would have good legal coverage. And within 90 minutes, within 90 minutes was in total pain relief. And that's been predicted in the literature. That's something we predicted. Dr. Castellanos was also very kind to give some, unofficial advice on all of that. But the literature was very, very clear. And also from my background in applied neurophysiology and a lot of the advanced certifications I got, I was very fortunate to already have a good sense of what would occur. And, so within 90 minutes, her pain was at zero for both her glossidynia, as well as the entirety of her whole right leg that had this pain distribution. But also, fascinatingly, and like we dared not hope, but it happened anyways, simultaneously, her 4 smaller toes had not moved in 9 years, because she had what's known as a phalangeal resection. So literally had the knuckles in her 4 smaller toes surgically removed because they were in so much pain. And it's just shy of an amputation. And some people almost consider it to be one, and so her toes had not moved in 9 years, and so that's a loss of mechanical input, which tends to actually gate and dampen down pain sensation, like noxious sensation that can rapidly become pain. And also it made her a fall hazard because her toes weren't working, tripping and falling. That's like a very high risk, like no joke, of a pretty severe injury, like on like every 1 to 2 months, she was making a trip to the emergency room. So anyways, and within 90 minutes, her toes were volitionally moving again. And that's after we had been working very specifically for like the previous 3 months on priming her nervous system with neuromechanics. So doing nerve glides for like her peroneal nerve, her tibial nerve, doing motor control exercises as best we could for that whole kinetic chain. Oh, Lynn is with us in the comments. Oh, you're tearing up. How do you think I'm doing with this? So it's just, you could not ask for a better client than Lynn Watkins, really Judge Watkins, just to be clear here. And, she dove in wholeheartedly. She trusted the process. She did everything she was asked. And this has to be highlighted, it was a leap of faith for her, in the sense like, most people with complex presentations of chronic pain are usually very, very compliant and dogged in their pursuit of exhausting standard. I know I say this each time I'm on here and all these other podcasts, but most of these people have exhausted standard of care treatment. They've done all the medications, they've done all the different types of physiotherapy. And it's just worth saying, like she really, really did everything that could be done and was just super diligent. And we think that's a big part of why it was as effective for her as it was, because that's kind of what I extracted from my experience. A lot of people go through these study trials and, perhaps the duration or the depth of their relief is not complete. And please don't misinterpret that as me saying they didn't do it hard enough or something like that. It's like there's a lot that goes into this. Like I just have even Dominique Morisano kind of confirmed, it's like, I had a unique background of training, so I was able to utilize the literature. Like I immediately sought out in my case, like, therapy with someone that was, trauma informed. And plus I was just literally troweling all the neuromodulation afterwards that I could do, but I had been going into the trial. So it's just like, well, we know these things work in neurorehabilitative practices. What are the best practices in that field? What are the best practices in the psychedelic field? And so where do those two things meet? And now it's like, as of a week and a half ago, it's been accepted for publication. And just super, super fortunate to Lynn was willing to share that study with the authorship team. So Dr. Joel Castellanos was the primary investigator there, and then Dr. David Javitovsky and Dr. Harman Chopra from NYU and Hopkins, were co-authors with Joel and me, and CJ Spotswood was our is REMAP's primary psychiatric clinician. And so a lot of the credit also goes to him in making sure, as Joel and I have talked about, as I've brought up, like most of the people that are coming into REMAP and that will be coming into this field looking for relief from chronic pain, it's going to be a complex presentation. It's someone that's probably been in the system for the better part of a decade, if not longer, and is polypharma. So they are on multiple medications. And, a lot of times what we hear from practitioners out in the field is like, there are those that feel strongly that they need to get their clients off of all other medications in order to not have these, like, competition for receptor occupancy, receptor affinity, that SSRIs may be, blunting the effect of psychedelics since they're serotonergic as well. But, is that the actual case? So based on CJ's research, as a psychiatric nurse practitioner of more than 20 years, it's like, well, no, that's not necessarily the case. Maybe in some cases we need a larger dose, or we need to, if not wean people or taper people off, we can taper them down a little bit, or we can say, if they're on a benzodiazepine, can we alter the schedule so they're taking it later in the day so it's not interfering with that neuroplastic window we're trying to engender, or does this compound have, in fact, a long enough half-life that they can stop taking it for a week and it's just not going to have a negative impact on that client's, health, performance, mental state, all those things. So we're looking for what advantages are there already in the literature, already in best practices. So that's a little long, but it's not a one size fits all. What's the risk to reward ratio of making someone rapidly taper off all their SSRIs? Because they're not only used for depression. A lot of SSRIs are used, in fact, for chronic pain and other conditions. And so it's like, is that going to be worth it? Are they going to be just in a state of advanced suffering by the time they reach us? And that's not useful if they're already at the end of their rope. So, I know there's lots of discussion around that, probably some strong opinions, but this is the route that, REMAP goes through right now. And we've had, just strikingly wonderful success following this approach so far. And we think we're well supported by, both the pragmatic practice as well as the literature as it's emerging.
How was the paper received at Pain Week or by some of your colleagues?
So it's gotten good traction online. And so I could just say, Zach Haney from the Trip Report has been super supportive and really seems to get it, which, just happy about that. In terms of people that I know directly that are within the space, they've been super supportive. And it's been one of those things where you see something, you experience something, you predict something, and the literature, like I'm saying, the literature predicted this already, and so I was talking about adjunctive therapy even before PHRI released their paper that was published in Pain Journal in September of 22, which had one of the first cases of adjunctive therapy to psychedelics, in the Albert Lin case study. I saw this, and then 2 months later, I find the Albert Lin case study of adjunctive, neuromodulation. And then, so it's like, okay, we're going to start trying to do this. And then, here comes Lin, and it just worked, beautifully, and whether that's the circumstances or just, the pragmatic application of what's already there, that can be parsed out further, though I did have a 30 plus year background in pain and performance and had been studying applied neurophysiology with things like neuromechanics, neurovisual modulation, tactile reprocessing programming, had been doing that for more than a decade and a half and longer if you consider some of my earlier practices. So it's just especially gratifying, though, just that it's adding to the literature. It's opening this idea up. So, and when people look at the complexity of her case, we didn't report all the good things that happened to her. It's like we had to narrow the scope of what was being discussed to mostly things around CRPS, but she had additional, very, very striking responses. And depending on where you classify ketamine, either, in terms of mechanisms of action or to experiential qualities and what it's doing to neuroplasticity. It's not like she was psychedelically naive, but she had never had the benefit of the psychedelic experience, let's just say, because like with most high dose ketamine for complex pain, she's out cold as soon as like the infusion starts. So, I think we are just on the cusp of discovering how broadly and deeply we can apply this.
Right.
I think we will see multiple forms of adjunctive therapy getting the benefit of adding psychedelics to the mix, and what the dosing frequency is, what the dosage level is, we don't know yet. Will there be multiple compounds, single compounds, things of that nature? Does the psychoactive effects need to be happening? I think they, for many cases, they do. Though maybe you start them off on something, non-psychoactive, and eventually introduce that, because so many of these conditions are bi-directional with PTSD, bi-directional with depression and things like that, and like we can have the impact of adverse childhood or earlier adulthood events really impacting those pain neurosignatures. And so it's like it's part of the combination, and we can address the things going on at the receptor level, things going on at the spinal cord and in the central nervous system, inflammatory burden, all sorts of things like that, cortical reorganization and whatnot. But if you're not including people's very, very specific internal experience of what that means to them in terms of identity, how they've been socialized, their family background, how that emerges within their occupational context, within their relational context, this has a very huge impact on people's families. It's really more like a family disease once it happens. Just because everyone has to shift everything that they're doing, and whatever trajectory they had is suddenly very different. So, if you're not unlocking the psycho, social, spiritual, emotional aspects, it's difficult to get a complete resolution. It's not impossible. I don't want to say it's impossible or that everyone has to do it that way, but I think it adds a pretty vital dimension to the solution.
So in terms of doing the science, you and I have had some interesting conversations about like how do we prove this at scale? So there's at least some sort of statistical model we can lean on. There was I don't even know if I talked to you about this yet. There was I'm fresh back from Burning Man. I'm still kind of deep in it. There was a art installation there that was called I'm Fine. And it was very big letters, like probably 30 feet tall or something. And it was made up of street signs, car doors, basketball hoops, all from Ukraine, riddled with bullet holes.
Fuck
And
me.
you and I have been, very impactful. Next to some other highly impactful sites. I think they opened up the DJ set with their air raid sirens that they use in Ukraine. So, gut wrenching, but also really impactful. And, you and I have been talking about just the sheer volume of limb loss survivors in Ukraine for a while. And,
Yes.
that would be amazing to be able to work with them and reduce the pain there.
So I'm going to be speaking with someone who works on the national stage, whose family is from Ukraine soon in another context, but that's something we've dialogued about back and forth for quite a while, just in terms like people need to understand, like in the first year of the Russian invasion of Ukraine, the limb loss count was somewhere around 15,000. And it's grown way past 45 now. I think the upper limit isn't completely known. And that's just limb loss. That doesn't include, like, say, limb denervation where, or nerve denervation where the limb is still there, or a mangled or a vestigial limb is still there, but the nerve is essentially dead in there. And that's producing phantom limb pain. Phantom limb pain doesn't require the loss of the limb to create phantom limb pain, or complex infections that can be going on where, so within a wartime condition, MRSA, which all of us are used to getting spread in gyms over here and hospitals over there. Like you have these, wartime battlefield conditions. MRSA is like just rampant everywhere. So, it's, you know what, in therapy, what FINE stands for?
Let's hear it.
When people say I'm fine, therapists quit back fucked up, insecure, neurotic, and emotional. All very appropriate for battlefield conditions. It's just such an urgent need right now. Of course, something that I've heard through and then got confirmed in the news, something I heard months ahead of this being reported in the news, like we can go to Gaza and say the pediatric limb loss and amputation rate is, it's just insane. We're talking children with, just very intense, complex limb loss, and at numbers that are hard to imagine. And this was something that was being spread through the rescue communities as well as the physiotherapeutic communities. And I can look back at my previous work, and you look at places where similar vicious wars are happening. So say Liberia or Sierra Leone, and like they had, war crime, active war crime amputations where people's, I'm sorry, everybody, should have said trigger warning way long ago here. Really should have, I apologize. But, you look at like Sierra Leone and the civil wars in Sierra Leone and Liberia, where people are having their limbs hacked off, at all ages, and almost nothing was done there to help those communities afterwards. So, this isn't something that's limited to one region, and you can look in the United States and, car accidents, and, cancer, and other conditions. We can talk about things like, gunshot wounds and stuff like that, all sorts of industrial crush accidents. It's pretty debilitating when it happens. You don't think about it because it's always there. It's easy to use, but once a limb is gone, I mean, everything becomes about compensation around it. So, yeah.
Well, thanks for that. It's a lot, and yeah, trigger warning, retroactive. I hope it works.
Sorry.
It's a tough. I brought up limb loss first and Ukraine first, so it might be. So it's a heavy topic, and I have the tragic suspicion that global war will accelerate over the next 30 years, and probably based on resource scarcity. So it's like, not only how do we get ready for the amount of grief that we're going to be experiencing, but how do we get people back to life, back to their lives. And pain treatments are going to be part of it, and then psychiatric interventions with psychedelics and psychospiritual interventions, etc., should all be part of it, because we need everybody back. We can't really afford to have people held back by major psychiatric diagnoses and neurological conditions causing outrageous pain. Cluster busters, PPA, MAPS, etc., like the whole thing. We need everything.
And I know that Elizabeth Ames' organization, Heal Traumas, has been doing extensive work in Ukraine to help those with complex PTSD, combat-induced PTSD, and really, it's not even PTSD. It's not post. It's active trauma that's going on. So they have been working with organizations over there, with psychiatrists within the Ukrainian medical system, as well as physicians, to help them with multiple psychedelic compounds. And I believe adjacent countries are helping with that. I think also there's, I'm so sorry that I don't remember the name of the organization right now. There has been an organization specifically that set up a prosthetic limb and rehab facility in Ukraine, just because they're completely overburdened with the numbers. On one of the previous papers I worked on long COVID and psychedelics, Dr. Monica Verduzco-Gutierrez, so she's the department chair of rehabilitative medicine at University of Texas, San Antonio. She's been visited by physicians and I think rehab specialists out of Ukraine who came to visit, her facility and just discuss, the level of intervention that's necessary. So, but I could absolutely see this continuing to go on. Like, no one's talking about what's happening in Sudan right now, but that's a massive humanitarian crisis with thousands and thousands of victims, and so and if you want to talk about even fewer resources, just go there. And unfortunately, there are things happening in Africa on a broad level now, where we see these regional conflicts spreading even further, with the same bad actors as before coming back to their old haunting grounds and doing the same bad things. So, that's a longer, broader story, but just in terms of where can we provide relief, there's no end of it here.
So let's bring this back to the symposium. What are the dates for the symposium, the Psychedelics and Pain?
So September 28th and 29th is when this is coming up. So just a couple of weeks. We've been very, very fortunate to be supported this year. So by, PPA has been supported by some generous contributions from both the River Styx Foundation as well as the Cohen Foundation that's helping sponsoring this event. So the very first day is a general level overview to anyone and everyone who wants to learn about psychedelics and chronic pain, as well as other physical conditions like infection-acquired chronic illnesses, neurodegenerative diseases, and autoimmune diseases. But that all are tangentially or laterally related to chronic pain. But the first day is free. The second day is our professional day, where we'll have, once again, as we have before, leading researchers in the field of study around psychedelics and chronic pain, presenting on their latest research. So either new investigation lines of thinking, as well as research that's been advancing or is pre-publication. So we're very excited. Some of that's going to be coming out that we've been literally tracking for the last 3 years. So that day is a sliding scale. But we'll have something for literally everyone. We'll have patient perspectives, people discussing how they used psychedelics in order to and found profound relief. So we have Marianne Wilkie-Lasange, who we've had on before, discussing her complete resolution around her long COVID by taking a combination of MDMA and psilocybin mushrooms together, and that practice. Then Lynn Watkins discussing her work that she did with REMAP Therapeutics, which was like adjunctive neuromodulation in combination with psilocybin mushrooms. We're fortunate enough to have a lawyer in the space, Ariel Clark, who also had pretty significant and profound relief to some very severe mobility problems she was having. Wasn't able to walk anymore, and psychedelic medicines were afforded her to be able to walk again. So, and she'll have a more interesting, or not more interesting, she'll have a different background to bring to it, because she's bringing some of her own indigenous perspectives to how she approached that. So that's very interesting to hear that within, a medical context, and so what are those psychosocial factors that also, for each person has a very unique take on this. I can assure you of that, and yet we see a place where they, once again, if we're spinning the combination lock, is that a number that we're skipping? We want to make sure that, at least that's represented or given space. So,
Yeah. No, thank you for that, Court. And
yeah,
I'm hoping to be there as much as I can, and
please.
very excited that it's going to happen again. So,
Yeah.
yeah, and just another reminder, everybody, Vital starts on the 17th of September. Orientation's on the 16th, but you can jump in a little bit late if you need. And there's still room. So please check that out, Vital Psychedelic Training, or just go to psychedelicstoday.com and learn more. Happy to answer any questions you have about it. And it's our 12-month training program for those with a professional interest in the space. So, Court, where can people find your website?
Okay, so the easiest one to direct them to, first off, so there's three, but we'll start off with for the Psychedelics and Pain Association, which will also have a link directly to the Psychedelics and Pain Symposium, is psychedelicsandpain.org, right? And we have a banner right across the top for the symposium. We do have a separate link for the symposium itself. In the meantime, I'll also direct you to my website, remaptherapeutics.com, right? And that's actually just about to get a web update. So don't be surprised if you get something, a redirect message in the next week here or so. But the last one, oh, I don't have it in front of me. If I had been clever, I would have had that with me right now. So, but if you go to psychedelicsandpain.org, you will find a nice banner sending you directly to it. Also, you can go through all my socials and you'll find a link to the symposium that way. So you can go to at REMAP Therapeutics for my Instagram and Facebook, as well as REMAP Therapeutics on LinkedIn. All of those have links to the symposium.
Well, Court, thank you so much for doing this. I hope people will check it out and join for the symposium. It would be lovely. And yeah, if you know somebody that's struggling with chronic pain, maybe have them check out the resources at the Psychedelic and Pain Association. It can be tough.
And just worth highlighting also, let's say you don't have 2 days to watch 16 hours of the top researchers available all at once. It will be recorded. Once you register, you can access those recordings afterwards at your own leisure. So, please don't feel constrained by time or space.
It's beautiful. All right. Well, thanks everybody for tuning in, and hopefully we'll see you again on a stream real soon. Take care.
Thanks so much.